All right. Hello, everyone. Welcome to Stump the Expert by the FIT Council. We're excited to have our participants here today. As a reminder, please keep your camera and microphone off while the presentation is going and the discussion. If you have any questions, please leave them in the chat and we will get them if time allows at the end. And I am going to hand it off to Dr. Ahmed.
Thank you, Taylor. Hey, everyone. My name is Amr. I'm a general fellow and one of the co-chairs for the Michigan Fit ACC Council, along with George Yasa. And we really appreciate everyone being here, especially the panelists. We're really looking forward to hearing your thoughts on this interesting case, and all the other fellows here who are attending and here to gain some valuable information, I think. Just to give some introductions. So the panelists will be Dr. Rita Coram. She's a interventional and a structural cardiologist at Corewell Health on the east side of the state. We also have Dr. Devraj Sukul, who's also an interventional and structural cardiologist here at Corewell Health in Grand Rapids. And we also have Dr. Seif, who's a cardiologist by training and also has done critical care training and works as a cardiac critical care intensivist, also at Corewell Health in Grand Rapids. And as far as the presenter, we have Liyan Obeidat, who's also on the FIT Council, and she's a second-year cardiology fellow at Henry Ford. And we're all looking forward to hearing an interesting case and just hearing everyone's panelists' thoughts on how they would manage it and how they would approach the case. And if you have questions along the way, please feel free to just send them in the chat and we'll ask them towards the end of the case. Otherwise, Liyan, it's all yours.
Okay, thanks everybody for joining, and excited to hear our expert opinion on this case that I've personally learned a lot from. Is everybody able to see my screen? Okay. So starting off with our case, I'm discussing a case of a 70-year-old female patient who has a past medical history of type 2 diabetes, hyperlipidemia, and a remote history of breast cancer that presented to us from an outside facility, initially presenting to the facility with worsening fatigue, shortness of breath, and some episodes of chest pain that was described as substernal and non-radiating. Her vital signs on arrival, the ones that were taken from the ED, she was afebrile, she was tachycardic in the 120s, 130s. Her blood pressure was 70/52 with a map of 57. And cardiology were consulted to evaluate. Just starting off, if a fellow is presenting such case for our experts, what would you expect to hear from the fellow, discussing more about the case, describing her physical examination, and what is the number one concern that our expert would have here?
I don't know if you have the moderator, if you guys want to call the expert so that we don't all speak at the same time, but I'll go first. So this is a patient who's advanced age diabetic. First of all, can you hear me well? Okay, advanced age diabetic and fatigue, shortness of breath, chest pain. So this is, we're thinking cardiogenic shock in this case, right? So for physical exam, I want to hear about the jugular veins. I want to hear about the extremities, cold, warm, wet, dry. That's as far as, physical exam, as well as, any murmurs. Sometimes those diabetics and females, especially at advanced age, they can have a late presentation with a mechanical complication of a myocardial infarction that was completed a few days ago. And they can present with something like this from ischemic mitral regurg, papillary muscle rupture, a VSD, etc. So those are all, they have physical exams that are pertinent.
I can move on if
I think Dr. Seif was about to have
oh,
something to add.
please.
Just in addition to that, how long have the symptoms been going on? Has this chest pain been coming and going? Has it been constant? Is it positional? Um, is the heart rate irregular or regular tachycardia? Um, muffled? Other things?
100%. So as far as the history, at this point of her presentation, most of the history were taken by family members, and they described that the patient has been feeling off for the past 2 days prior to presentation with on and off chest pain. She wasn't really exerting herself, so the symptoms were present even at rest at that time during her presentation. It wasn't radiating as far as we know, and they did not describe, she did not describe to them any tenderness or anything that we were able to produce in her presentation. I can talk more about her general appearance. She was definitely lethargic at the time point where she presented. She was pale. Her tachycardia was regular. She was in sinus tachycardia. No significant murmurs were appreciated on her exam. She did have a JVD though, and had good air entry bilateral, but bibasilar crackles were appreciated on her exam. Her abdomen was soft and non-tender. Her extremities bilaterally were cool to touch. No significant lower extremity edema otherwise. Her skin was mottled as well, and examining her capillary refills were also delayed. She was very slow to respond. She was on and off following some commands. She did not demonstrate any focal deficits. We got a set of labs for her on her presentation, which this is what her metabolic panel showed. Definitely showed evidence of low bicarb with high anion gap. Her creatinine was 2.2 from a baseline from 0.7 to 1. And this was her ALT and AST on presentation with prior normal with no described liver etiologies in the past. This was her initial lactate on presentation between 5 and 6. Her BMP was in the 2000, and we do the high sensitivity troponin, and this is the maximum that the lab would report more than 20,000. So this is how she presented, and those were her blood counts on presentation as well. Does that bring us closer to more of a diagnosis here, or we would want to know any additional labs or anything different?
Yeah, I'll chime in here. Great presentation thus far. I think adding on to what Dr. Coram and Seif mentioned as well. I think your physical exam findings as well as your biochemical assessment seems to be confirming the suspicion for certainly shock, and I think the exam most consistent with cardiogenic shock. I think the question we have to now dive down into and dig into is what is the underlying cause? And I'm sure you're going to get down to this, but coming on to Dr. Coram's point and Dr. Seif's point, understanding the temporal course, is it 2 days of fatigue, shortness of breath, and chest pain? Was the chest pain stuttering? Did she kind of feel unwell and then suddenly decline? Those may give you hints into trying to put together ultimately the pathophysiology of what brought her in. But you clearly have end organ dysfunction here, hypotension, and your high sensory troponin has an interesting pattern of potentially a delayed infarct.
Right. She by the family, it was reported that she needs some help of some of her daily living activities. But overall, she's like able to get up and like bathe herself, dress herself. They help her out with groceries and stuff. And before these 2 days, there wasn't a gradual decline. It kind of started off waking up fatigued and kind of sweaty with this on and off chest pain that kind of persisted for these 2 days before declining and bringing her into the emergency department.
And sorry, real quick, was she hypoxemic?
She was not hypoxemic. She was on room air on presentation. Sorry that wasn't reported. And this is her initial EKG on presentation. We did not have a prior to compare with. Does that is that of a concern for anything acute, anything old?
So this is a sinus rhythm, right? I can't tell if this is left bundle, but it's in that direction. I'm surprised to see. So I was imagining an EKG with Q waves from V1 to V, to like an entire anterior wall with biphasic T waves by now, because in my mind, this is an anterior STEMI, large territory at risk, delayed presentation in older female who usually have atypical symptoms of fatigue and shortness of breath, diabetic. I'm a little bit surprised, but it's still, an abnormal EKG.
With this presentation, would we activate a cath lab for this lady?
She's in shock.
And this is a follow-up EKG where she went into AFib with RVR. And this was her chest X-ray. This was an old port related to her remote breast cancer history. And then we see the little bit of pleural effusion here and the vascular congestion that is suggestive of some pulmonary edema here. This
Yeah,
is
I have a question, I think, at this point. Yeah, Dr. Seif, go ahead.
Just backing up a little bit with the EKG, did she, not specifically the EKG, but any new medications in the last week or any recent procedures? And what is the status of her breast cancer?
not that was reported anything new during what she usually takes. And the status of her breast cancer, she is in remission as it was reported to us last, and she's just on surveillance. I wasn't really sure why the port wasn't removed still at this point, but this is as far as we know as her oncological history. In terms of what she took previously for breast cancer, I think her chemocycle therapies did include a doxorubicin at the time of diagnosis at some point. So that was included then. And I think at the time she got to us, she was only on the maintenance hormonal therapy on her presentation.
Just for considerations of MCS, what are you trying to get back to? What is your, baseline? Do you have active stage 4 cancer? Those things to think about before
100%.
Getting to MCS.
100%.
And kind of in that vein, I'm curious if you could speak a little bit too. I think there's a little bit of balance between rushing this person who's in cardiogenic shock and not doing well to the cath lab, but then also stabilizing them before they get to the cath lab. I'm just curious if you could speak a little bit to the logistics of that, kind of your thought process of, do you get them up into an ICU, get them stabilized, and then get them to a cath lab first? Do you stabilize them right in the ED to the cath lab, or try to stabilize them in the cath lab itself?
That's a hard one. That depends. Throw them on pressors and see if you're able to perfuse them. If you're still not and you think they're an MCS candidate, then the conversation needs to happen more quickly and going to figure out what was the cause. I would put a probe on her chest, try to make sure that this isn't, like previously mentioned, a pap rupture or something that is a valvular issue. And like if this is severe AI, no MCS is going to help you in that situation. So kind of knowing what you're working with right before you go.
Yeah, I agree. The echo is important, and you want hemodynamics as well, right? So
let me see. This was her parasternal lung axis. There was a little bit in the range of moderate MR here, but there was no concern of papillary. I didn't put all the echo, but there was no concern of mechanical complications at this point. There was no pap rupture. There's nothing suggestive of free wall rupture, VSDs. But we can clearly see the global hypokinesis here. And I don't know if anybody else would like to comment on anything else on the wall motion.
it's global, but do you have an apical 2? Was it global on the apical 2 as well?
It was global on the apical 2 as well. Yeah, I don't think I put it here. But it was global on the apical 2, and I have the summary of the full report at the end here. Her EF was estimated to be in the range of 15 to 20%. Again, global hypokinesis, grade 3 diastolic dysfunction. Her RV was also generous in the moderate range for enlargement and moderately reduced RV function with PA systolic pressure of 54 with pleural effusion also reported. So we ended up taking the patient to the cath lab. From the outside hospital, she came in to our cath lab. And this was her angiogram.
Liyan, I would just kind of pause you, and I just want to ask Dr. Sukul and Dr. Coram,
Yeah.
in this setting with a patient like this, for this presentation, they're going to the cath lab. What kind of access and what kind of things are you thinking about as you take them to the cath lab, as far as the need for support and the need for hemodynamics, the logistics of all that, and the order in which you do things? I think that kind of matters here.
Yeah.
Yeah, go ahead, Dr. Coram.
No, go ahead. I mean, this is not someone you go with a radial access because so access would be ephemeral, but go ahead.
Yeah, no, I mean, I think to your earlier point, Umar, at the end of the day, I think we all know that 2x2 blocks of heart failure or shock, or however you want to categorize it, wet and dry and cold and warm. Whatever you want to do, you want to get them warm fastest. You can worry about the cold and dry. And so, in an ideal world, everyone gets to the cath lab and we just get hemodynamics and we get mechanical support in and get them perfused how we think fit. But in the real world, you're going to put them on a pressor and you're going to see what direction those labs and them how they do hemodynamically. And so I think, obviously in an ICU with very up-to-date vitals and you're tracking them, putting a swan in even at the bedside, that's probably the route you're going to go. I'm curious, did you all go to the cath lab from the ED, or how was that done? Because that's really a practice pattern question, how different hospitals do it.
From what I remember, she was at an outside facility. We got the call for her to come to the CICU. We were concerned enough that we discussed with the cath lab person, and we said we can just bring her to cath lab. There was no swan put in at that point. So we wanted to get hemodynamics, shoot the coronaries, and go from there.
Yeah, and so I think from an access standpoint, you're going to put a leave-in swan. So you go in, put that in up front, get your numbers. And then, I agree with you. Unless there's some contraindication to going femoral, if they're massively obese, etc., I would just start femoral, shoot your coronaries, and then figure out what mechanical support device you're going to be able to put in.
Mm-hmm.
Agree.
Does your management or an approach to a patient change in this scenario where you don't, I think we're still a little bit unclear whether this is acute heart failure, cardiogenic shock, or acute MI versus someone who's coming in with an anterior STEMI, or are you still approaching with that similar mindset? Or are you rushing the cath lab faster? Or are you still trying to stabilize them in the CTICU? How do you approach that?
Yeah, I mean, I think at the end of the day, it's not technically an anterior STEMI. I think you have to act based on how um, poorly the patient is doing and what their trajectory is, in terms of what you've tried thus far and if it is working or if it is not.
Yeah.
Going to the cath lab is not without its risks,
Mhm.
and you want to make sure you're doing it in the right state of mind rather than just doing it and saying, we're going to learn all this information without a cost. There is a cost to it. So just being cognizant about that. So my personal opinion would be I would do my best to see how some inotropes work in terms of perfusion, and then get a swan in at the bedside and figure out where to go from there.
Yeah, and she was on Levophed at this point, of course, hypotensive in the cath lab. And these are they playing okay for everybody?
So the thing here to think about is if this is not an anterior, like if this is not a STEMI, you want to do your best before you go to the cath lab and start adding insult to injury with contrast to an LV that's got an EDP of probably 35 to plus, because they have very little perfusion window, and injecting contrast to that can actually there's a cost to that. So if this is not a STEMI, I would stabilize them first before they go to the cath lab.
Are you referring to MCS first?
See if you can get them warm with pressors first. MCS, maybe the right heart cath is going to be the IJ right heart cath hemodynamics will help a lot in that. And then eventually the patient is going to go to the cath lab, of course.
Yeah.
Just the idea that, and you're going to see this in your practice at some point, where the patient was okay and alive, and then just administration of contrast can just spiral them.
Right.
Because they had so little reserve left.
Right. And I will show the right heart cath numbers. We can since I have these first, we can go through her angiograms.
Just a technical question for Dr. Coram, Dr. Sukul. In a scenario like this, do you think about which coronary artery you're shooting first? I know some people will say, they shoot the one that they least suspect first, and then they go up with a guide catheter and shoot the one that they suspect is the culprit, versus some people don't really care. Do you have a preference to how you approach that?
I like if I know this is an anterior STEMI, I take a quick picture of the right just to know that I have backup before I go with the guide to the left, and vice versa. If it's an inferior STEMI, I do diagnostic left quickly just to know, because I would do things differently if I have a beautiful left main LED left circumflex rather than critical, right? You go in quick and out rather than spend time and more contrast, and then it tells you much more about whether you need mechanical support, etc. But in this case, since I'm not thinking this is a STEMI, I would go with the left, and this is just my own preference. Why? Because if someone codes after the first injection for whatever the reason is, contrast allergy or whatever, having had 2/3 of the vessels understood is that that's why I go left first. This way, if something happens, at least I've seen the left main LED left circumflex, and I have more information. 2 out of 3.
Yeah, I think very similarly. I do the same. I don't think that it makes a huge deal. I think the thing you want to know here is you want to use as little contrast as possible to get the best angio images you can. So that doesn't necessarily mean don't inject a lot of contrast when you engage the vessel. It just means inject enough to opacify fully, so you're not taking more injections because you've streamed, etc. Right? This person already has acute kidney injury. I'm sure the baseline creatinine is not 2.2. She has shock liver, so you don't want to add insult to injury based on your diagnostics here.
Heidi, thoughts about the angiogram?
Yeah, this is a critical distal left main, calcified vessels extending into the ostial LAD, proximal circumflex. OM1 has a tight lesion. I don't know if the mid LAD has anything, but there's plenty with the distal left main. TIMI 3 flow.
Mm-hmm. And this was
And then the RCA, yeah. So then the RCA is it's not playing here, but it's 100% mid. I don't see any bridging collaterals. I don't see left to right. So perhaps the RCA is acute. I don't know. It could be subacute, that RCA.
I think this is the only thing I've added for the RCA, but on more views, the collaterals were probably more evident. This was called a CTO with right-to-right collaterals here.
Yeah, I think it's a little harder on our end, but there's probably a conus to marginal collateral
Yeah,
that
I can
very
imagine.
faintly now is coming down, but
Mhm.
yeah, otherwise, could be acute. Would be hard to imagine that this alone would be the cause of such dramatic shock, but in the setting of the bifurcation disease of the left system, it could certainly tip someone over.
And those were our right heart cath numbers, which did show elevated pressure, biventricular filling pressures. Her RA was 23 range. Her PA was 70/29 with a mean of 47. Our wedge pressure and LVEDP were about 33. And then her PA saturation was 56%. And by FACC, we got a cardiac output of 2.9 and a cardiac index of 1.7. Her cardiac power output was 0.47 and PAPI was 1.78. How would these numbers change our next step here?
She needs unloading.
Mm-hmm.
Yeah, impressively, PAPI's not terrible. So left-sided support, start with left-sided support only. See if you can decompress the right by forward flow of the left, decompress the strain on the LV.
And your choice of MCS would be an Impella.
I would. I don't think the balloon pump will get you there. It depends on what your cath lab is able to do. But I would
Yeah, and
probably
then
choose the Impella CP.
yeah, I think that's right. Obviously, assuming there aren't relative or strict contraindications to it. So.
Balloon pumps don't unload much. They increase coronary perfusion, but they don't really unload much. This would be an Impella case, but also is it Impella for PCI or Impella for bridging? But it would be an Impella case for me. Left.
And with MCS support, would the intervention happen at the same time in the cath lab, or is there should there be a discussion with CTS, or what would the approach be from your experts?
Yeah, I wouldn't rush into doing a PCI. based on these hemodynamics without any unloading or further therapies to potentially make the PCI safer and more effective.
Agree. You have TIMI 3 flow. You just need to decrease myocardial edema, perfusion pressure at the myocyte. So unloading is going to help achieve that, and the vessels later.
And this is what ended up happening in the cath lab at that time. An Impella CP was placed, and after the Impella placement and repeating the hemodynamics, again, PAPI did not drop any further. It's slightly improved even with improvement of a little bit of improvement of the filling pressures and the cardiac index, giving us an indication that we are heading in the right direction just by LV unloading here. That also helped the right side. So she ended up leaving the cath lab with the Impella CP that was placed in her right groin area. She was treated for a high risk and semi-cardiogenic shock and was started on the aspirin and heparin. And in our ICU, she was on maximal Impella CP support at P9. Additionally, she required a little bit of norepinephrine that was ranging between 5 and 10 mics per minute. She was evaluated by cardiac surgery in the setting of her diabetes and left main LAD involvement, and she was deemed a pre-surgical candidate by them due to high operative mortality, using the STS score showing the operative mortality of 26%, morbidity and mortality here in the 57% range. So cardiac surgery was deferred. With the Impella support and unloading, we were able to see these changes in the lab where her creatinine has much improved and normalized, trending down of her LFTs and improvement of her PA sats in the range of 65-70% and normalization of her lactate as well. In terms of timing for intervention, what would be the best period to intervene in such cases?
She cleared her lactate, her renal function is good, you've unloaded her. This is next day?
This took about 48 hours for
Still in at P9?
Yes.
And she's not hemolyzing, right?
She was not hemolyzing. I don't have the LDH here, but no, there was no like clinical concerns of hemolysis. Her LDH was at reasonable ranges. She remained in her stable baseline anemia with no further worsening.
That's a very good question. My vote is go on now. Don't wait.
Yeah. Yeah, I think you don't want to leave the Impella in too long. You obviously can't predict the future in terms of how long it can be left in for each patient. I think the only other question I would have is clinically, how's her mental status? Did that improve as well? You obviously want to understand goals of care on top of all this, right? It's not a low risk PCI by any means. So you do want to just make sure we're all on the same page in terms of continuing aggressive care.
Very good question.
Yeah.
Mentation has much improved and was back to normal. And again, discussing more with family about her breast cancer history and functionality. She's not that active of a 70-year-old, but she was functional enough at her baseline, and everybody was in agreement with her decision making that if a PCI would help with her symptoms and her overall survival, everyone has opted to move forward with the procedure, which is what ended up happening.
I have a quick question here. Sorry, Liyan. Dr. Seif, as an intensivist, like how long with patients like this are you comfortable sitting with them and before you start asking the proceduralists and the surgeons to intervene? Obviously it'll depend on clinical course, but in general.
This is interesting because she cleared and normalized so well. You would be within your rights to ask the surgeons to come back and reevaluate and re-echo her and turn her down. And, if you think this is all just ischemia rather than infarct, your EF may improve. In your STS, that was a very high STS, understandably multi-organ shock, but she would probably have a better STS. And if they thought this was all ischemia, we have 5-5'd them, gone to the OR, bypassed them, come out on 5-5, recovered them for a week, and then take out the 5-5, and they recovered nicely. So if you believe this is all ischemia driven, now, her functional status is a little concerning. So I think I would, at this point, this is probably your window. You don't want to sit them on Impellas, 5, 6, 7 days. You're asking for hemorrhage, stroke, kidney failure. So this is probably your window.
Yeah. This is
I
actually
think
this is a
go ahead,
very,
Dr. Coram.
yeah, this is an excellent point that she cleared so well. Her STS score is different. There's, reassessment is such a good point.
I think the final thing I'll bring up is where's the evidence for what we're doing in these situations? And if we're being completely honest with ourselves, the evidence for revasc in multivessel disease with low EF is not terribly in favor of PCI. Just being frank, we do it. We're going to do it in this case. We're going to continue to do it in our lives. But the largest one studied, most contemporary, is a trial called PCI Revived out of the UK and showed no benefit.
Yeah.
The second question is, where's the benefit from CABG? And that comes from the STITCH trial, not even the primary STITCH trial, but the extended evaluation of the STITCH trial, which was over 10, 15 years ago now. So kind of keeping that in mind, obviously in a diabetic patient, multivessel disease, CABG, if feasible and not, prohibitive, should be done. And so I think just keeping those considerations in mind as you're undertaking high risk things, as we are doing, I think still very reasonable to do it in this case because we have, hypothetically speaking, things to do. But what if there's infarct and it doesn't improve? Maybe just getting her on good heart failure therapy, which has very good evidence for survival, is also the right thing to do, and is obviously going to be done ultimately here.
Yeah, I think that's very helpful. I wasn't available at the part of rediscussion with the surgeons, but from what I saw going through her chart, the decision was final that they were leaning towards still high operative mortality, and the rediscussion did happen for sure. I made sure I went through her notes, but the decision did not ultimately change. So she ended up going to the cath lab for PCI at this point, which happened after 72 hours. So that's day 3 from her presentation to us. The PCI happened with the left main and bifurcation with rota and shockwave used here. I'll show the pictures of post-intervention that we have. And the right heart cath following the procedure with attempting of weaning down her impella support and kind of relooking at her filling pressures did not show that he was like fully optimized by then yet. So the decision was made to not remove the impella in the same sitting and kind of reevaluate in the CICU more of an extended wean of impella before we ultimately opt to remove the MCS altogether. This was I just got the final results here following the intervention that has happened in the cath lab. And I wish her story ended up here with improvement. However, this is actually where I got involved in her care. I was on call that night. She came back from the cath lab at the beginning of my shift. We went to check on her initially. So this intervention happened from her left groin area, and the impella has remained in the right groin area. So initially, when I checked on her, she was her sides, both right and left, they looked okay, which we make sure to check following patients coming back from the cath lab. Hermentation was good and stable since before the cath lab as well. And I kind of went around to go check on other patients. However, over the course of the next 1 to 2 hours, she started becoming more tachycardic. This was the change of her blood pressure here, and which is started getting softer and softer. She was back from the cath lab. She was about like 3 mics of norepinephrine, which has steadily been going up during this like 1 to 2 hours. Her impella started suctioning, giving us suctioning alarms, and we actually noted decoupling of the LV and aortic waveform on her impella. For a person coming from the cath lab with such heavy procedure and such change of hemodynamics, what are the things that we should be looking for here in this case?
Number 1, bleeding. Number 2, bleeding. And maybe number 3, bleeding. But no, I'm serious. So you guys know that you could do single access with the impella, right? You could go
Yeah.
through the impella sheath and save the patients from access complications. But I'm assuming the EKG doesn't show STEMI, right? With this.
So, yeah, we definitely rechecked the EKG, which did not show STEMI or anything to suggest that
Like no stent thrombosis.
acute.
And then the fact that you're having all of those alarms
Mhm.
with shock, makes me wonder if this is a hemorrhagic shock.
Right. And would like pericardial effusion and tamponade present in similar way, or such presentation, or number one would remain the hemorrhagic shock?
That's a good point. I don't see why it wouldn't present in the same way.
Mm-hmm. So,
I guess
yeah.
just real quick, Dr. Seif, if you could, and you do a lot with managing impellas, if you could speak a little bit to alarms and how you approach and troubleshoot.
Yeah, I also noticed her pulse pressure is really narrowing, 70/64, 72/67. Um, agree with the bleeding, 1, 2, and 3, examine the patient, but also grab the probe, make sure that with separation of your waveforms that you're not displaced in your impella because you just came up from the cath lab and got transported.
Good point.
Suction, it could be still in and sucking a pap up because it twisted and your elbow's down now. Again, volume, if you're hypovolemic, you will start suctioning, but positioning can also give you suctioning with normal filling of the LV. I would make sure, I don't know if this woman is she extubated on room air or is she intubated, and trying to figure out if she's bearing down or other things that are contributing to this impella alarming, because if you
She was
raise your,
she was not intubated, no.
okay. Then yeah, at the bedside, evaluate the patient, examine, but grab the probe, make sure you know where your impella is as well, and you can see what you're doing. That would also give you the answer for the pericardial effusion.
Mhm. So an EKG that was done, it was unchanged. Bedside echo showed no pericardial effusion. We did notice a rapidly expanding left groin hematoma, and immediate pressure was applied. And we've been on her groin for this past hour. However, it was clearly expanding beyond our ability to control that at bedside, with the worsening of hemodynamics and decoupling of the impella. We ended up activating back the cath lab as opposed to getting her to like a CTA and such, so that it will be also taken care of in a timely fashion in the cath lab. Labs during this showed a drop of her hemoglobin from 9.2 to 7.6. She was definitely more pale and mottled at that time. Activating the cath lab, a peripheral angiogram revealed that there was active extravasation from her left common femoral artery. Balloon tamponade was initially attempted for 15 minutes. However, post-deflation of the balloon, active extravasation was noted. So she ended up requiring a covered stent in that area in the left common femoral artery, using IVUS for appropriate sizing and follow-up. And post the covered stent, there was no active extravasation that was noted.
Quick question out of curiosity, what access was used to do this procedure?
For this procedure, they used the left radial artery.
Did you give blood already when you saw the bleeding in front of you?
100%. The blood bank was contacted, and we had 2 units hang before she went down to the cath lab, and we also ordered more to the cath lab that continued to be given throughout the case. I think overall she received 4 or 5 units, eventually overcorrected her hemoglobin, but in the setting of the active bleeding that was happening, and until this was figured out, we were transfusing until we made sure there was no active extravasation that has persisted.
This was a common femoral artery puncture, or was it high?
I think the puncture was a little bit high, looking back at the angiograms, this is where we noted the active extravasation. For whatever reason, the peripheral, I would love to show the peripheral angiogram. I don't know that not everything was sent over to the single system that we've been using, so I wasn't able to showcase the active extravasation. But this is what ended up reported, and the procedure happening in the cath lab.
Did it go to the retroperitoneum as well?
Say that again.
Did it go to the retroperitoneum as well?
Yeah, the active extravasation was leading to an RP bleed as well. Yep.
And just for educational purposes, what was the antithrombotic regimen that was given in the cath lab?
At the time of the intervention,
PCI, that's what PCI.
she was already on heparin, and she was loaded with ticagrelor, if I'm not mistaken.
No way.
And
there was no other 2B3A or anything like that.
No additional.
Yeah. That's great. And then, just depending on where you go to practice, not all the equipment will reach the common femoral, depending on the patient's size, from the radial, sorry. Right, because your right femoral is occupied with your impella. You can't use left femoral because it's bleeding. So you have to use radial or brachial. Terumo makes a lot of equipment now for radial to peripheral interventions that'll treat mostly iliac. If it's a short enough person, you can get to the common femoral, which it sounds like it was in this circumstance. If not, you can go brachial and get there.
Right, right. And from what I heard from our interventionals, it definitely wasn't the easiest delivery of the covered stent through that. And more time was spent in the cath lab, and I think vascular surgery were around because of initial concern about like the delivery system not being able to get
Get
out
there.
smoothly or get there smoothly. But ended up happening okay that night. And um, following controlling of the bleed, her color has immediately improved, and this decoupling was no longer there. And over the course of the next couple of days, she was nicely weaned down from the impella and back to the cath lab for removal, and eventually to the floor. And I think this is everything that I have for this case.
Nicely done.
Very good case. You know, it's not surprising. This is going to be a case, unfortunately, lots of you are going to see. And it was said before by Dr. Sukul that going to the cath lab is not without risk. So think about it twice before you do it. But good case. I try my best to stay as a single access for the go through the impella sheath. 10 o'clock, 2 o'clock. I really try my best to do that because bleeding has been uh, clearly shown in so many studies that by itself increases mortality. And that's the whole premise of radial access, etc. Because, even in the best hands and the best technique, bleeding happens, typical, right? Older female. And she was on heparin for the impella, right? So we don't even know what happened to that heparin. Did they hold it? Did they keep it going, right after the access to the femoral artery? Was it done with ultrasound guided? Was it with a micropuncture? Was it a single anterior wall puncture? Was it multiple, jabs? It's just so tough once you touch femoral arteries of old women and men, but women.
Yeah, very nicely done. I think the only thing I'll add to the bleeding part is that's how they die quickly. If you don't recognize it, particularly if they don't have the hematoma, you still have to suspect it. And they not only have worse outcomes because they bleed, but they frankly have worse ischemic outcomes because we often reverse their anticoagulant after a fresh stent, and then you're now dealing with another problem. I agree with single access. Obviously hard in the setting when you've taken out your sheath for, you're doing this 2 days later. So you've taken out the sheath, you put in the repositioning sheath, so you can't now go through that. But to all the fellows out there, hopefully those interested in doing intervention, really focus on good femoral access. We do a lot more PCIs radially, which is great, but there are going to be times where you need to go femoral, and you still got to be able to know how to do it really well.
Yeah, very nice job. Thank you. Just a comment on the P9. I wouldn't keep your impellas at P9, on the floor. That's kind of your ramp up. It'll ramp itself up and down. P8 is really what, your maximum on a CP. To avoid hemolysis, you tend to get it anyway. So it's very impressive that she normalized so fast.
Yeah.
So
Really impressed.
Cool. Awesome. Well, thank you, everyone. Thank you, Liyan, for a great presentation. And thank you, Dr. Seif, Dr. Coram, Dr. Sukul, for giving us your time on a Thursday evening and really giving us your valuable insight on walking through. These cases are always complicated because they're so individualized and it's not a cookie cutter way of managing things. So it's always great to hear your own personal approaches to these cases. There's just a comment that Lucas Rich put in the chat that Dr. Sukul, your point is really well taken about just taking a pause to reflect on what benefit these patients get, even in an acute setting, whether we're pursuing PCI or surgical intervention.
Yeah.
Bradley?
Just want to say thank you to everybody as well, and great points from everyone. This was wonderful and a complicated patient. Devraj, again, the data that you also mentioned was something to definitely think about between acute intervention with PCI versus CABG in these patients. And you almost jinxed it when you said initially, taking somebody to the cath lab has a cost potentially,
Yeah.
and here you saw it. So yeah, congrats. I was just surprised as DEP, the EKG when you first showed it did not look as bad as I thought it would be.
Yeah.
It makes you wonder about how long she presented. It took her before she presented, but thank you everybody. This was wonderful.
Very good.
Thanks, everyone.
Everyone.